All right, leading us off today, we have Dr. Lily Yao, in vivo senior scientist with product development, and she'll be discussing preclinical evaluation of efficacy and cytokine release of bispecific T-cell engagers in humanized NSG mice. So welcome, Lily.
Thanks for the introduction, Jenny, and thanks to everyone out there for tuning in. Bispecific antibodies are emerging as a promising approach for cancer immunotherapy. Bispecific T-cell engagers, or BiTEs, are a type of CD3-based bispecific antibody that direct T-cells to kill tumor cells. During this presentation, I will share some in vivo data for evaluating two novel BiTE antibodies using human tumor xenograft models in humanized NSG mice. Before I get into the data, I'd like to briefly describe how the tumor-bearing humanized NSG mice are generated in the Jackson laboratory for immunotherapeutic drug evaluation. First, young NSG mice will be conditioned with whole body irradiation, and then they will be injected with CD34 positive hematopoietic stem cells. We check human cell engraftment levels in the peripheral blood by flow analysis around 3 months post-stem cell injection. Mice are considered humanized once human CD45 positive cells are more than 25% of total cells in the peripheral blood. We then implant human tumors, PDX or CDX, into mice with human immune system for efficacy studies. This humanized mouse model has strong T-cell reconstitution and has been shown to be useful for the testing of antibodies targeting T-cells. Bispecific T-cell engagers, or BiTEs, are fusion proteins that are designed to harness the T-cell mediated immune responses against cancer cells. It has been shown that BiTE antibodies activate T-cells by cross-linking the TCR-CD3 complex with a tumor-specific antigen. So T-cell can recognize tumors regardless of their TCR specificity and trigger cell killing. A number of different tumor targets that have been explored using the BiTE approach are in clinical development. Blinatumomab is an FDA-approved BiTE against B-cell antigen CD19 for relapsed refractory ALL and has activities on non-Hodgkin's lymphoma as well. We evaluated the anti-tumor effect of two novel BiTE antibodies using our tumor-bearing humanized NSG models. One is anti-EGFR BiTE and the other is anti-BCMA BiTE. Here is the efficacy study design using EGFR CD3 bispecific T-cell engager antibody. So MDA-MB231 is an EGFR positive triple negative breast cancer cell line. The solid tumor model has a fairly high level of T-cell infiltration when growing in humanized NSG mice. We took advantage of this feature by using anti-EGFR BiTE to engage the existing T-cells in recognizing EGFR tumor antigen. So tumor cells were also topically implanted into memory fat pads. Two CD34 donors were used in this study. For the prevention trial, we start dosing when the tumor would just become palpable. For the intervention trial, the treatment was delayed until tumors become established. Mice were dosed three times a week for both trials. I will show the following data sets, including efficacy data, body weight change reflecting treatment safety, serum cytokine data, and T-cell activation in response to drug treatment. The efficacy data is not separated by donors, since both donors responded to BiTE treatment similarly well. A 2-week preventative treatment regimen inhibits tumor growth and resulted in complete tumor regression. Tumor from the treated group remained unpalpable up to 4 weeks without treatment and then started to grow back, while the control group reached the endpoint due to tumor size limitation. 4 weeks of BiTE intervention treatment did not eradicate established tumors, but they effectively inhibit further growth. Mouse body weight and clinical observations were checked 2 to 3 times a week. Overall, the treatment was tolerated in both studies, as evidenced by no significant body weight loss. Mice lost some body weight during treatment, but their body weight recovered quickly when dosing was stopped, as you can see in the prevention trial. Literature reports have shown that acute cytokine release often occurs using T-cell engaging therapies. So 16 hours after each dose, we collected blood for serum cytokine analysis. Cytokine data from the prevention group are shown on the top, intervention group on the bottom. We observed transient cytokine release in the BiTE-treated group after the first 2 doses. Levels then returned to the baseline with continued dosing. In addition, cytokine levels seem to be higher in the intervention trial where tumor size is bigger. We used human Th1, Th2 CBA kits to analyze 6 human cytokines, and we were able to detect interferon gamma, IL-6, and IL-10. The other 3 cytokines are undetectable. We analyzed T-cell frequency and T-cell activation in the peripheral blood by flow analysis. Blood was collected 16 hours after the last dose. We did not check tumors in this experiment since most of the mice in the BiTE group didn't have palpable tumors. The flow data was similar for these 2 studies. In the BiTE-treated group, T-cell frequency in the blood decreased significantly as compared to the PBS control. The percentage of CD69 positive, the activation marker CD69 increased after BiTE treatment. Here is a quick recap of the EGFR CD3 BiTE efficacy study. 2 weeks of preventative BiTE treatment resulted in complete tumor regression. Tumors from the treated group remained non-palpable up to 4 weeks without treatment. 4 weeks of BiTE intervention treatment protocol did not cause complete tumor regression, but still show treatment benefit by inhibiting tumor growth. Anti-EGFR BiTE treatment was generally tolerated in both studies. BiTE treatment induced some body weight loss, but body weight recovered quickly after dosing ceased. This observation will be in line with the rapid clearance of BiTE antibody. BiTE treatment increased cytokine release level, but the increase was only temporarily and occurred after the initial 2 doses. This drug's anti-tumor efficacy was long-lasting. Flow analysis The flow analysis of blood taken after the last dose showed that BiTE treatment decreased T-cell frequency and increased T-cell activation in the peripheral blood. Next, I will discuss an efficacy study using BCMA CD3 bispecific T-cell engager antibody. So BCMA stands for B-cell maturation antigen, is primarily expressed on plasma cells, and it is known to promote multiple myeloma pathogenesis. NCAH929 is a multiple myeloma cancer cell line expressing BCMA. Tumor cells were subcutaneously implanted into humanized NSG mice. 2 donors were used in this study. Each group had 10 mice per donor. Mice were grouped for dosing when tumor become palpable. This study didn't use large tumors. I will show efficacy data, body weight data, and human cytokine levels and flow data for tumor T cells. We saw donor-to-donor variation in response to BCMA CD3 BiTE. The donor on the right shows significant tumor growth inhibition after BiTE treatment. The donor on the left did not respond. At the end of the study, we saw 57% tumor growth inhibition and a significant tumor weight reduction in the responding donor. Mouse body weight was monitored 2 to 3 times a week after dosing initiation. Both donors showed significant body weight drop, about 10% loss the day after the first dose, and the following doses did not result in further body weight loss. Actually, body weight gradually recovered despite continued weekly dosing. We examined the cytokine release profile in response to BCMA BiTE treatment at 6, 24, and 48 hours after the first dose. BiTE treatment induced elevated levels of human interferon gamma, TNF-alpha, IL-10, IL-6, and IL-2 at 6 hours post-dose. All the cytokines returned to the baseline levels when checked at 24 and 48 hours after dose. Both donors show similar cytokine release profile in response to drug treatment. We also checked T-cell frequency and activation in the peripheral blood from the 6-hour time point by flow analysis. Both donors showed decreased T-cell frequency and increased percentage of T-cell activation after BiTE treatment. And BiTE-mediated T-cell activation is in line with the cytokine release data. Tumors were collected for flow analysis at the end of the study. After BiTE treatment, the frequency of tumor immune cells increased in the responding donor, but not in the non-responder. BiTE treatment resulted in increased CD3 T-cell frequency, and the majority of the increase was from CD8 T-cells. This increase was also more pronounced in the responding donor. Both CD4 and CD8 T-cell in the PBS-treated tumor had a high percent of CD69 expression when compared to T-cells in the blood. This percentage was further increased after BiTE treatment and was higher in the responding donor. In summary, NCIH929 tumor growth inhibition by anti-BCMA BiTE showed donor-to-donor variability. We observed significant growth inhibition in one donor, while the other donor did not respond. We saw a first dose effect for this drug. Body weight decreased significantly after the initial dose and began to recover afterwards. Human cytokines IL-6, interferon gamma, TNF-alpha, IL-10 were elevated, and T-cell activation were also observed after the first dose. T-cell frequency and activation increased in tumors after BiTE treatment. The increase in the responding donor was more pronounced. So in conclusion, I presented our in vivo evaluation of 2 novel T-cell bispecific antibodies using tumor-bearing HSC humanized NSG mice. We took advantage of robust T-cell reconstitution in humanized mice and BiTE-mediated T-cell activation to do efficacy study. We observed strong anti-tumor efficacy, increased cytokine release, and T-cell activation after drug treatment. This is the end of my presentation. Thanks for listening.